Welcome to another edition of Nurse to Health, where we take you to the front lines and behind the scenes in healthcare. Brought to you in collaboration with the Hofstra Northwell School of Nursing and Physician Assistant Studies, and always with the incredible support of John Mullen, who runs this studio, and the radio station is our engineer as well. So welcome everybody, and with that, let me welcome Professor Tomeka Robinson. Hello, Tomeka.
Thank you.
Tomeka is, you're welcome, Senior Associate Dean of the Rabinowitz Honors College here on the wonderful Hofstra campus, and Professor as well of Rhetoric and Public Advocacy. And you may be wondering what all that has to do with healthcare, but I can assure you it does, and that's what we're going to explore. So take you in another direction today. Just before we get started, we always like to bring a personal aspect to these conversations. So tell the audience a little bit about your background.
My research background is in health education, so the intersections between health, policy, communication, and culture. So I do a lot of research on issues of how we enact our agency, how structures and culture both enable and constrain the choices that we're able to make about our health behavior, about the choices that we can make, and how all of that just kind of has this really big impact, even if people don't think about the ways that those are a part of the conversation of health.
For sure. We'll get into it a little deeper at the medical school and now at the nursing school. I mean, we make a big point about communication. I mean, it's a whole track at the medical school just for providers in terms of how they interact and talk with patients. I mean, the old paradigm was sort of a big power differential, and, I'm the authority figure and this is what you should do. That's gone by the wayside, thankfully, and but also on the other side for patients. I mean, I have this conversation often about even people who are educated and people with resources. It's still incredibly challenging to have a discussion with a healthcare provider for all sorts of reasons. So can you dive into all of that a little bit?
There's a few different reasons why that exists. From the provider perspective, it's understandable. They've gone through a lot of training. They know what they're talking about as far as the diagnosis. They know the science parts of it that the patient doesn't know always. Sometimes the patient knows a little bit more than they are given credit for, but it is understandable that they are saying, like, I am the provider and I'm here. From the patient's perspective, they know their bodies better. They know the things that they're experiencing. They know their history, even if they can't put it into words. So there's that embodied knowledge that is also a part of the interaction. Within the medical field, over the last, I'd say 20 to 30 years, there's been a lot more movement of understanding not just the patient as a biological organization, but it started with this biopsychosocial model of trying to understand more of those lived experiences, socioeconomic status, education, how all of those things are also a part of the medical examination. But there's also, and that's where a lot of my work and other work, like by Mohan Duda and others within the field, have really tried to interrogate that a little bit more and say, no, we have to also think about culture and think about the impact of the ways that the lived culture that we're in also has a part of that conversation. So they proposed the culturally centered model of health, which really looks a little bit more into what agency do you actually have? Are there biases that both the provider and the patient have of each other in an interaction? And how can that make a big difference on not just the care that they receive, but also the relationship building? So there's a lot more work that's being done that's really interesting, that's very engaging, but it also provides a challenge for both the provider and the patient on how do we undergo or how do we negotiate the power differential within a medical setting of you are the patient, I am here, and there's limited time, there's limited personal history and stuff that is there. How do you overcome those things, and why should you take that step to overcome it?
So yeah, why should you?
Better care. If the patient feels more comfortable with their provider, they're more likely to be honest about, their diet, their environment, their sexual activities, drug use, alcohol use, any of those things which can and do have impacts, even their supplement usage. Sometimes patients don't feel comfortable telling their doctors that they take certain supplements, like even pre-workouts and things like that. From the provider's perspective, providers get into the practice because they want to care for people and they want to do the best job they absolutely can. So for the provider's perspective, having more of those insights and having more of that honesty, knowing more, gives them more pieces to the puzzle on how can they provide the best care to their patient. So for both people, it is more beneficial to have a deeper understanding of it, knowing full medical histories, knowing as much information as possible is mutually beneficial, and it takes time. It takes a lot of energy. It takes a lot of effort. It's not something that's just going to happen overnight. It is that relationship building and that co-construction of the healthcare environment.
Yeah, that's fantastic. I mean, there's just so much to unpack there, right? I mean, we tend to use is shared decision making. I mean, it used to be authoritarian, and now it's like, listen, you're coming to me as a patient for preventative care or actual care for a problem. I teach my students that the root of the word doctor, the Latin root is doctore, is to teach, as a teacher. Doctors need to teach. You know, the idea is, the paradigm is to let your patient know what you know. Don't talk down to them, talk in simple terms. So you bring them on board and you can actually engage in a shared decision, because everybody's going to have different goals in life, different risk aversion, etc. So what might be good for one person, right, is not going to be good for everybody else. And you can't put yourself in the role of the patient. You have to educate them so that they have the ability to come up with an informed decision. I mean, we throw that term around, informed decision, but a lot of times it's not. It's a quick checking off of boxes. So yeah, look, you touched on the matter of honesty and trust, and I'll ask you to talk a little bit more about that because it's so important. I mean, we throw around the term here and, you know, elsewhere, the term safe space gets thrown around in society. It's a pet peeve of mine in some ways, because people will say, hey, listen, this is a safe space, trust me. In real life, that's not going to happen, right? Like you said, you walk in, you've just met somebody, and you get the feeling you're not connecting with them, quote unquote, right? In terms of language, in terms of background, in terms of culture, in terms of shared experiences. And all of a sudden, you're asking them very intimate questions, right? Yeah, tell me about your personal sex life. Tell me about, you know, possible drug use. Tell me about this, that, and the other thing. I mean, I know, I'll speak for myself. I'm not coming clean, right?
Most people won't. I mean, and that's a natural
Talk about
thing.
That, yeah.
You know, and that's why, you know, developing and having, and there's such a benefit to having a primary physician. So having someone that hopefully you have built that relationship over time, and you're probably going to be more honest with them than going into the emergency room or an urgent care or a one-time situation, because yes, you have gotten to know them. You may know their families. They may know your families. Like, there is something about building that rapport over time, because absolutely no one's just going to walk in and be like, yep, person I just met for the first time ever. This is how often I use drugs. Here's how often I do X, Y, and Z, because it's just not going to happen.
Yeah, let me show you my track marks. Yeah, right.
Yes.
Yeah, right.
But all of those things do have an impact on the health. It does have an impact. Like, if you haven't disclosed, I'll use alcohol usage, for instance, because a lot of people, you know, drugs and stuff like that, that's a more salacious one. But even with alcohol usage, most people aren't going to say, yeah, I have a beer every night.
Yeah, I get drunk every night on the way home. Yeah, that's right. Yeah.
But certain medications do interact inappropriately or have negative ramifications for having any alcohol in the system. So that is something that the provider does need to know. And if the patient isn't honest about that or doesn't feel that they can be honest about it, that can have a very negative and sometimes deadly interaction for the patient.
Yeah. And, you know, sort of as a matter of honesty, I'm going to introduce my co-host who just walked in, but don't do it again. Don't be late. This is my co-host, my wonderful co-host who, you know, was out saving the world and teaching students. So
I think that's a good excuse for being late.
He's got a good excuse. But with that, welcome Kareem, Dr. Nagdala. Why don't you just say hello and introduce yourself?
Hey everyone, hope everyone's well out there.
Honesty makes all the difference in the world, because you touched on some of the reasoning, but you know, sometimes there's a default in society at large, and this holds true for providers and patients. It's like, hey, just, you know, we don't need to talk. Just order me an MRI, right? That'll solve all the problems. That'll give us the answers. It just ain't true.
Nope.
Okay? I mean, it doesn't work that way. But there's a tendency to do that. You say, I don't need to talk to you. Oh, yes, we have to have a conversation. We're going to discover some things that we're not going to pick up necessarily on imaging. We're not necessarily going to pick up on lab tests, or we just don't know where to, where to start, right? So, Karim, you want to jump in on any of that?
Yeah, I mean, it's the new age that we're living in. It's all like cookie cutter sort of stuff where people, they look things up online. They're like, yeah, I already know what I want. It's almost like you walk into a dealership. It's like, I want a red one with no navigation and black rims. We have to talk to these people because it's, without that human connection, you don't really know what's actually going on with them. It's not enough. Like the textbooks, I know we're just giving a lecture, but the textbooks, they don't cover that human aspect of it.
And from the patient perspective, they also, with direct-to-consumer advertising of prescription drugs and stuff, they come in and like, well, I want that drug. Why can't I have that? And the doctor may know something deeper about why you can't have that, or that it's not going to actually treat whatever's there. So it is a mutually beneficial relationship to have those conversations. But also the doctor should talk to the patient about why they can't have that, or why that is not the best protocol or treatment for them.
Following up on that, here's something I'm going to invite you to talk about, which ties into diversity and equity issues. So we talk about it, at least, in the healthcare world, we talk about root cause analysis, but it's not a healthcare idea. I mean, that's out in the world. The concept of root cause analysis, just to pick an example, somebody walks in with chest pain. It's like, oh, why do they have that? And they do an EKG, there's changes on the electrocardiogram. Well, why is that? We do some further studying. There's a blockage of an artery, and why is that? Well, because, their cholesterol is high, and why is that? And a lot of whys, and we keep going. And usually we get to a point where we say, okay, well, hey, HDL, LDL, some other parameters are wrong. And it's like, okay, you need to change your diet. Here's a sheet you need to read, or, maybe we'll refer to your nutritionist, and that's where it ends. But that's not where it should end. And I'm going to invite you to talk about that because, well, why aren't they eating right? Is it an educational thing? Can they not afford it? Are they working, 20 jobs and don't have time to shop properly? Can you talk a little bit about that?
Yeah, there's so many things, and that's where the agency and culture and what choices you can actually enact come in, and that's where I started with this conversation. Because as you said, can they afford it? Do they even have access? So thinking about food deserts. So if the only thing that is available in their neighborhoods that they can quickly access are your local bodegas or the fast food restaurants and stuff, then do they really have the choices to enact that? No. Thinking about affordability to where fresh fruit and vegetables, like everyone's like, everybody can eat fresh fruits and vegetables. Fresh fruits and vegetables are actually quite expensive. Yeah. Recognizing that, getting I'll use grapes, for instance. That's what I use with my students a lot. I don't know why. But like getting like a package of grapes, it's like $5 for a package of grapes. You know what else I can get for $5? A value meal at McDonald's. What's going to last me longer as far as me feeling full, me having the caloric intake that I need to get through the day? It's going to be that McDonald's. Now, is that McDonald's having a detrimental effect on my health? Yes, but it's a trade-off that people have to make honestly all the time. Can I make this longer term investment into my health of spending a little bit more money on it? Or do I need to keep my lights on? Do I need to make sure I can get to work? Do I need to make sure that my kids have something to eat? There's all kinds of issues and stuff that are there that we really can unpack quite a bit more. There's entire looks when I lived in West Virginia. There's an entire thing that is called Mountain Dew mouth. And what that is because of the extreme poverty of a lot of the people, the mothers are so concerned about just making sure their babies have something to eat. So they're putting Mountain Dew in their bottles because calorically it's giving them something, and a bottle of Mountain Dew is a lot cheaper than a bottle of formula.
Wow.
And it's just looking at the tooth decay and everything else that is happening there. And it's so bad that they've given a name to it and tried to educate a lot more about breastfeeding and those things. But we do have to, again, have those deeper conversations about, can't just give them a prescription to say, no, don't feed your baby Mountain Dew. You also have to think about, what are the structures that are there? Are there WIC programs? Are there SNAP programs and stuff that can then deal with that extreme poverty to where they have access to what we know from a health perspective is healthier?
So I'm glad you mentioned West Virginia. Not that I necessarily want to talk about West Virginia. No knock on West Virginia, but, our audience probably, I don't know, do we have anybody listening in West Virginia?
Well, you might. You never know.
I want to bring it close to home, because we tend to talk about in the abstract. I had a session in one of my classes the other day. We were talking about human trafficking. My students were amazed when we had Jerry Hart right here, head of security at Hofstra, talked about a local, regional problem. And the students were like, wow, we had classes on, global trafficking. We didn't realize what an issue it was. So let's bring that back to what we're talking about now. All these issues about food deserts and the rest of it. And what can you tell us about that on Long Island?
Well, I mean, a lot of people think that because you're in the suburbs, it doesn't exist. And that's not true. I mean, some of the incredible work being done by some of our professors right here at Hofstra, Dr. Martine Hackett, Dr. Corinne Kiriakou, lots of people are already looking at, the suburban health disparities. Hofstra is located in a food desert. People don't want to talk about that, we are this expensive private school. We have access. And yes, we do have a lot of incredible wealth, but we're still situated in a food desert. So some of us, like all of us sitting here, have the access and the ability to leave and go get the fresh fruits and vegetables and everything else that we need, or to enact healthier choices, not live in environmentally risky areas. But Hempstead, Freeport, Uniondale, Roosevelt, all of these spaces, there's a lot of health disparities that are there, to where if you cross between Hempstead and Garden City, you see a very different thing just looking at green spaces. And the impact of trees and having access to full service grocery stores and stuff, we can't negate how that makes a difference into the choices that people can make. And as you said, their cholesterol rates being elevated, having, higher rates of diabetes and other things, asthma rates, those are all environmental things, but it's also, can they actually do the things that we're telling them to do?
Yeah, and I'm glad you mentioned, shout out to some of the really good people here, Corinne Kiriakou and Martine Hackett, Brett Bennington, who are doing work supporting community gardens and, studying this stuff, publicizing it, testifying before whatever committees they need to. So they're doing that good work. Kareem, do you have any sort of experience with any of that?
I actually have a lot of personal experience with this, because I live in a community called Coram in Suffolk County. Coram is like a weird sort of place. It almost reminds me of when I did my undergraduate nursing degree at Adelphi. In Garden City, you could go from Garden City to Hempstead, and it was almost like flipping a light switch. So Coram is like that in a way. In the part of Coram that I live in, which is North Coram, you have beautiful colonial homes, big homes, a lot of people. I find myself to be well off. But then you cross Middle Country Road, and it's like you're in another country. I'm president of Coram Civic Association. We do a lot of work with people in the community. And I literally just got off the phone yesterday with a realtor in the area. I'll keep them nameless. But along Middle Country Road, there used to be a Stop and Shop that was there. And the closure of that created such a vacuum. I have the ability to drive to go wherever I want to get groceries. The other residents of Coram don't necessarily have that ability. And even if they did have the ability, I know people who live in a very nice home, but they're elderly on a fixed income. They're forced to drive 5 miles, 6 miles one way and then the other way. So you're talking about 10, 11 miles, 12 miles. It's just crazy. You don't really understand what people are living through unless you actually talk to them about it. The difficulty that I've had, at least trying to attract a supermarket to Coram, is unfortunately some of these, we talk about structural inequalities, some of these corporations that like to pat themselves on the back for diversity, equity, and inclusion, they don't really put that into practice. I don't see them in certain areas that are diverse. I just don't. We have that trouble. I spoke to a grocer for, again, I won't name the supermarkets. I don't want to. I don't want to get any liability. But I'll tell you that they basically said, there's the demographics aren't what we're looking at. And it's like, oh well, what does that mean? Should people not have access to food because they look a certain way, or because that's something that you can't change that. I don't know. It sucks. It's weird because even if they do have the money, it's just how they look.
I haven't had the experience the same way you have. When you become aware of it, you see it, right? It's one of these things, it's an awareness issue, right? People just drive by and, in a big rush don't pay attention to it, which is why we need these conversations to take place. So, your former life in some ways, or at least part of your former life, was in forensics and debate and stuff. How does that inform this discussion in terms of the skill sets needed? I mean, we're not debating patients in healthcare, but does any of the skill set translate? And
so interpersonal communication,
Yeah.
absolutely. Intercultural communication. So yes, as you said, it's not the debate part of it, but it's being able to articulate, who are you? What are you going through? Having the right language, being able to understand it, asking the right questions from a doctor's perspective, knowing that there is these other parts that, if someone's not making eye contact, is it because of cultural reasons, or is it because they may be experiencing, domestic violence or any of those things? Like, being able to pick up on those things is a part of the environment, which is why health communication exists as a field. And that's what I really teach, and I really process. My work is really grounded in health communication and health education, because I think it goes both and. We need to educate people on what they don't know, and then we need to know how to communicate that same knowledge into communities with doctors, with patients, with legislators, thinking through with those corporations and stuff about, okay, so just because they look a certain way doesn't mean that they can't afford it, and that they're going to come because that's the option that's available. So, being able to translate, really complex stuff into small digestible things is a part of it. So yes, I credit a lot of that to my debate background and my communication background. But I think that it's a little bit bigger. I don't think as you said, you don't have to debate with your doctor, but you need to co-construct with your doctor. You need to tell your doctor if they are writing down something like, nope, that's not accurate. As you just said that, I have a history of X, Y, and Z, like having access to your patient portals, looking through what's there, and then having deeper conversations and not just taking, the doctor said do this thing and that's not accurate, or this doctor said that this is what's wrong with me, that's not accurate, is having, as I said a little bit earlier, that co-construction of the environment.
So I'm going to take the flip side of that. I mean, all that's incredibly important. On the flip side, how important and how much time should we spend on listening skills, right? Because that's the flip side of communication. We tend to focus, just like, we watch sports, we focus on the offense, right? The defense gets a short shaft. They shouldn't, but, right, it's always like, the scoring records and all of that sort of stuff. It's a little bit more emphasis on that. Same thing in communication. It's like, what did we say? What did we ask? To that question, listening skills.
So I don't actually think it's the flip side. I think listening is a part of communication.
Sure.
So even when we teach public speaking, for instance, we talk about audience and audience feedback and getting those feedback loops. So that's where that nonverbal part, and we talk about listening and defensive listening, offensive listening, all of that is a part of it. So I actually don't think it's the flip. Now, I think in our common understanding, we only think about when we are speaking as being a part of communication, but we're never not communicating. Right. And a big part of it is also, listening for those cues, things that are not said. What is the subtext that is there that is so critical to the environment for all kinds of reasons. So you mentioned earlier, you missed that, about, they may not say, here's my track marks, but if you see those track marks, those are those visual cues and stuff that as providers you should also be listening for or looking to, attuning yourself to.
I love that you brought all that up, because, I emphasize that for sure. And we just had this conversation the other day. So when does the engagement with the patient start? It doesn't really start when they enter the room. Before, as they're coming down the hall, if you hear somebody shuffling down the hall, okay, there's a clue. If you hear them stumble, if you hear them cough, if you hear a conversation they're having with somebody who's accompanying them, those are all clues. They walk into the room. Yeah, of course, there's going to be verbal communication, but how are they dressed? Are they unkempt? Are their shoelaces untied, et cetera, et cetera? All clues for a healthcare detective, right?
They are clues, and we do have to be careful with some of that about, how we
talk about that.
Attribute certain biases to certain things, like how they're dressed, right? So I'll use wearing urban attire. That doesn't mean that they're uneducated. It doesn't mean that they don't have the knowledge or the ability to enact things. And there is often that perception that, people of color and people who look like they are from a lower socioeconomic standpoint won't listen. They're going to be non-compliant. So we do have to be careful. So we can look for those cues, and I'm not saying not to look for them, but listen more to what is actually happening and realize that sometimes our own biases that we are not even aware that we have can also impact that relationship, and we have to listen harder. We have to push past those implicit biases and stuff and really ask those deeper questions and not just stop with what we think we can visually see or what we think we know about this patient just by those interactions.
Yeah, Laura, I'm glad you emphasized that. Yeah, absolutely. And I didn't mean to suggest that, we draw any definite conclusions.
I also think
yeah.
On the flip side of that, it also goes both ways,
oh, yeah.
right? Because if someone appears well-dressed or something, maybe we might form a bias about that person, like, oh, they're going to be super compliant, or you know what I mean? And that's not necessarily true. So it's interesting. It's very interesting.
Right. Great point. Mm-hmm. There's some things that'll be more objectifiable. I mean, I was thinking more in terms of somebody has nicotine stains.
Yeah.
On their hands.
Of course. Yeah.
But I mean, look, the other stuff, don't jump to conclusions, right? Because a lot of times they are based on implicit bias, and keep an open mind. If there's something you're suspicious of, follow up on that, and if it's verifiable, that's fine. But don't draw biased conclusions for sure. How about touching maybe on some of your own personal, to the degree that you're comfortable doing that, your own personal interactions within this context of communication?
I mean, I think that a big part of it, and, you and I have had this conversation, and we've talked about this even with students and stuff before, to where it's like, I do this stuff every single day. That does not make me immune from these interactions or these implicit biases or things that happen. So I do a lot of work in reproductive justice and a lot about, understanding abortion as healthcare, but also, deeper situations within the treatment of women within medical situations and women, not just cis women, but also trans women in situations, right? So it doesn't make you immune. I do this. I have a doctorate. I have great education. I have great insurance and everything else. Have I also had situations where nurses and doctors didn't treat me well? Absolutely. But even when I was having my son, so I had to have an emergency C-section, and they actually messed up my epidural. So I was leaking spinal fluid for a few days, but I did not know that. So I'm telling the nurses the next day, like, I got this headache that just won't disappear. I was told, do you drink coffee? I say, yes, I do drink coffee. Well, you're having caffeine withdrawal. Let me give you a cup of coffee. Fine, whatever. I drank the coffee. Still didn't go away. And I continue to complain about it, but there's still that, kind of that suspicion of, oh, this person is seeking drugs. They just want painkillers and those things. It was like, I absolutely don't want any kind of painkillers if I can avoid it. Mm-hmm. But at the same time, there's a perception. And it wasn't until I stood up and fell to the floor that they started to investigate more. And that's when the doctor was called in, and they realized that I had been leaking spinal fluid for 3 days. There was all these things that could have been dealt with days before if there wasn't that perception of, well, I already know what it is. You drink coffee. That's what it is. There was nothing deeper that was interrogated. There wasn't a bigger conversation. And even as a patient who is very educated, I didn't push them either into it, because I was like, well, maybe I am having caffeine withdrawals. It doesn't feel like that, but maybe they are right, since they are the medical professional in that situation.
There's an intimidation factor. There's a trust factor. We're talking about trust, and so you have to gain trust. But, there's an implicit trust in authority, right? Even for somebody, and it's not just you. I mean, my God, I've had this conversation over and over and again, and I'm sure, I've been in those situations. Kareem, absolutely. How about you? I mean, when you're on the other side of things,
I had a situation when I was in college. I actually had pancreatitis. Now, I'm Muslim. I don't drink, so I don't know how I got it, but I had pancreatitis, and I was in a hospital. I'll keep them remain nameless. I was in excruciating pain.
Like not Northwell, just...
Yeah, I was in excruciating pain, and they basically treated me as if I was a drug seeker, and I'm like, guys, I am first of all, it's against my religion. I'm the most clean-cut guy that there is. I don't want this stuff, but, I did have that experience. I mean, it is what it is. I think part of that has to do with the fact that, to a certain degree, it's a job like any other job, and people kind of go on autopilot and they see patterns of certain things, and I don't think that they're intentionally doing it, but it happens.
Absolutely. And that's why having these conversations and having more training in how to get past those implicit biases, how to understand. So, one of the questions that they ask you in your medical and often in your intake is your religion. Well, if you have a patient who has checked the box that they're a Muslim, then it's probably not alcohol as a part of the conversation, right? It's not to say that couldn't be, but more than likely, probably not.
Right.
So it's having those deeper training beyond just the clinical training of you see this, it has to equal that thing that is necessary in our training, in our pedagogy. Yeah,
I mean, in healthcare, we deal with, and again, not just in healthcare, but in healthcare, for sure, we deal with likelihood ratios.
Yeah.
I mean, I think it's more likely or less likely. I mean, it's hard often to get to 100% negative or 100% positive. But, again, somebody, seems like they're being forthcoming and they don't drink and, then, all right. So, keep it in mind, but let's look for some other causes. So sort of in that context, what advice would you give to, a lot of our listening audiences are healthcare providers, but a lot of them are also in training. So what sort of advice within the context of communication and all we've talked about would you give to future healthcare providers?
When you are in your classes and stuff, sometimes those classes on health communication, the culture, interpersonal communication and stuff, those are offered as electives. So take them. It's going to make you a better doctor. It's going to make you a better clinician, whether you're a doctor, a nurse, whatever. It's going to make you better because you're going to understand a lot more of that. So broadening our understanding of medicine, taking public health classes, taking, things that are outside of just a direct training to here is how you draw blood. Those things are important. Please continue taking those because I want you to know how to do that. But I also want you to take some deeper things. And that's the beauty of a liberal arts education. That is the beauty of students who go to four-year institutions. Those gen eds are not just there to be barriers. They are there to make you better, not as just better workers, because I don't believe in education just being for work, but being better people, being better global citizens, being better, just interacting in the world. So being careful of how do we select those things, not just what is going to be that easy check the box so I can get that distribution credit or that gen ed credit, but being intentional. I want to be a good physician. Let me take an interpersonal communication class. I want to be a good nurse. Let me take an epidemiology class. Let me look outside of just what is the prescribed curriculum and really try to understand. Beyond just classes, educate ourselves too.
Yeah, I mean, that's such great advice because, maybe people look at that as sort of quote unquote soft skills. We don't need to know that. We need to know the other stuff that you mentioned. It's what makes us human. If you're not doing that, future healthcare providers, guess what? AI and robots will do all the other stuff. We got to preserve and maintain and improve on that human connection. Otherwise, forget about it. Well, hey, listen, this has been great. Thank you so much, Tomeka. On behalf of my wonderful co-host, who's never going to be late again.
Never.
But he had good reason. Dr. Karim Nagdala, and on behalf of John Mullen, our wonderful recording and engineer and head of this studio, I just want to thank you again, Professor Dr. Tomeka Robinson. This has been great, speaking about communication in healthcare. And thank you out there for tuning in to another edition of Nurse to Health, brought to you in collaboration with the Hofstra Northwell School of Nursing and Physician Assistant Studies right here on the wonderful Hofstra campus. And as always, try to bring you behind the scenes and to the front lines. Until next time, stay well.